coming back to the idea of continuum of care, later line treatment approaches add to survival. We've known this now for quite some time. So until recently, we didn't have a lot of interesting third line or fourth line options. Now we actually have two distinct agents, Regorafenib as a multi-kinase inhibitor and TAS-102, which is a fluoropyrimidine, fluorothymidine, so chemotherapy. And those agents are now kind of competing for the third line space. And the question is, how do we sequence these treatments? Who are these patients who should receive one drug or the other? Now, they have very distinct differences in terms of not necessarily efficacy, but toxicity. TAS-102 is a chemotherapy agent, conventional chemotherapy. Main side effect is neutropenia. We actually know that patients who develop neutropenia have better outcome on TAS-102 than patients who don't develop neutropenia. But this neutropenia is relatively asymptomatic. Patients normally do not have febrile neutropenia, so lower rate of infection. And some patients might have diarrhea, some patients might have fatigue, but normally TAS-102 is quite well tolerated. The pool of patients I consider for TAS-102 is larger than for Regorafenib, because Regorafenib has subjective toxicities, hand-foot skin reaction, aphonia, rash, fatigue, loss of appetite. So this is what patients actually feel. Now, we want to make sure that patients receive all active agents. That's one of the key principles of dealing with metastatic colorectal cancer patients. So how do we ensure this best? And this is where the evaluation of toxicities comes into play. I do believe that a patient who is a candidate for Regorafenib in a third-line setting should receive Regorafenib before TAS-102, because if we choose TAS first and patient's performance status deteriorates, these patients might not be good candidates for Regorafenib anymore, so we lose one treatment option. So with the goal in mind to really expose patients to all active agents, it is more prudent to use Regorafenib first, followed by TAS-102 in patients who are considered candidates for Regorafenib. Again, the pool of patients that are considered for third-line treatment is probably larger for TAS-102 than for Regorafenib. I would not treat a patient with a PS2 with Regorafenib, but I would treat a patient with PS2 with TAS-102 upfront. Now, this might actually change now that we have interesting data combining Regorafenib with immunotherapy and TAS-102 with bevacizumab. So these are new developments, new combination therapies that we will need to see what place they'll have in a third-line treatment setting.